Today we have a fantastic discussion about PCOS with Dr. Prati Sharma, who is a reproductive endocrinologist. She's been on our show many times before, and she's a fertility expert from CReATe Fertility Centre in Toronto, as well as Dr. Grace Liu, who is a gynecologist at Sunnybrook Hospital. So given that September is Polycystic Ovary Syndrome Awareness Month, we're going to be discussing PCOS today, and this live is really focused on practitioners who might see PCOS within their practice and how doctors like Dr. Sharma and Dr. Liu can help and support and guide you as practitioners to be able to have great information so that you can care better for your clients. So with that, I'm going to let you two ladies introduce yourselves a little bit briefly, and then we'll get into some great questions.
Thank you so much. I can start. Yes, I've been on the show a number of times, and I think this is a super timely topic given September and PCOS Awareness Month. And, you know, it's kind of unique that I'm doing this with Dr. Liu, because the last one of these we did together was on endometriosis. And I think endo and PCOS, one of the common threads between those two is that they're incredibly prevalent, often misdiagnosed or not diagnosed, and patients kind of live with these disorders and are not able to seek treatment. So it's great that it's out in the open and we can talk about this, the diagnostic tools we have, lifestyle management, and you know, what we can do to help these patients. From my standpoint, I see PCOS more in the early years, and I help patients who have PCOS conceive for the most part, but I also see patients who are not trying to conceive, who are just frustrated with some of the stigmata and the symptoms, the irregular cycles, the high male hormone symptoms. And sometimes it's not just about getting them pregnant, it's about mitigating their symptoms and making their life easier. So that's the standpoint that I come from.
Thank you. And Dr. Liu, maybe you can introduce what this means to you and how you see it within your practice.
Hi, everybody, and it's nice to see everybody here. And I wanted to say thank you, Julia. Thank you, Grow with Treehouse, for shedding some important light on this topic. Sometimes I think that women's health is not as addressed as importantly as other topics. And I think, of course, as being a gynecologist along with Dr. Sharma, that, you know, we clearly think that it's very, very important. With respect to PCOS, I mean, I see women after they've gotten pregnant by Dr. Sharma's capable hands, and I see them during pregnancy, and I also see them prior to pregnancy, just like Dr. Sharma, and as they get closer to menopause. And so it is like bread and butter to the gynecologist, you know, what with respect to the hyperandrogenism, the anovulation, and as they age, the increased risks of certain types of cancer.
Mm-hmm. So let's get started with giving our viewers today a bit of a background of PCOS and what causes PCOS, and giving them kind of the next few minutes to really understand kind of PCOS 101, really, is what we're going to do over the next few minutes. So I'll leave it to either of you to answer really what causes PCOS. What are some of those symptoms that we see in that presentation?
Yeah, I mean, I can start. So PCOS is actually a bit of a misnomer for the disorder. It's called Polycystic Ovary Syndrome. And so one of the first things I hear patients say when they come to me and they say, my family doctor thinks I have PCOS, is I have lots of cysts in my ovary. And that's actually not completely true. PCOS is a clinical disorder. It's multifactorial. So we don't really know what exactly causes it. There is some genetic component, family history. There's probably something immunologic. Certainly it runs in families, and lots of sort of genetic tests have been done to see if it's like related to an insulin receptor or an androgen receptor, but it's really been proven that it's multifactorial. Lots of things can affect it. And so when we diagnose someone with PCOS, it's based on, if you ask for the scientific definition, it's based on something called the Rotterdam criteria, which historically involved a group of reproductive endocrinologists and gynecologists who sat around a table and said, these are the common threads that run across for PCOS. And so they developed this criteria. And the criteria is polycystic ovaries on ultrasound. Even though I said it's a misnomer, it's basically having multiple follicles surrounding the edge of your ovary. Anything over 12 that are located as a string of pearls around the ovary, and there's a classic ultrasound diagnosis, is considered polycystic ovaries. Just as a caveat, everyone who has these polycystic ovaries doesn't actually have polycystic ovary syndrome. So you have to really be careful with the diagnosis, because I find a lot of family doctors sort of label patients as PCOS just because they look at their ovaries and they see this string of pearls appearance. It has to additionally have one or both of the other clinical components, which is oligomenorrhea, which is prolonged cycles that are 35 days or more apart. Sometimes they don't even exist, and clinical or laboratory signs of high male hormones. And typically this presents as women who have symptoms of excessive hair growth or hair loss, insulin resistance, acne symptoms, sometimes darkening of the skin. Those are mostly the common ones, difficulty losing weight. And that's really the common thread when we see PCOS patients, and that's how we make the diagnosis. And as I said, it's multifactorial. We really can't nail it on the head why someone has this. And typically we look for those things as clinicians when we're trying to diagnose a patient. And I'll hand it over to you, Grace, if you have anything additional to add on that.
Yeah, I agree completely. So multifactorial, so there is likely some sort of genetic component, but as with all things, there's also an environmental component as well, and we don't know what triggers one thing or another. And again, like Dr. Sharma said, you need 2 out of 3. 2 out of 3 things to make the diagnosis of the polycystic ovarian syndrome. And it's either the anovulation, so not ovulating regularly, the hyperandrogenism, so the male factor hormones, or the ultrasound finding. And the only other thing I would say, just to add, is that very careful when you're making the diagnosis that you don't diagnose it just because it says so on an ultrasound. You have to take a history. And you really have to ask the patient, because they get concerned, because we always give our ultrasounds to the patients and they can see, oh, polycystic ovarian syndrome. And all of a sudden they're like, oh no, like I'm diagnosed with that. And that's not the case. And so I think it's a little bit of a combined thing where maybe we should be also talking to our ultrasonographers to be very careful when they kind of label patients with that kind of polycystic ovarian morphology. And then the other thing, the last thing for any family doctors listening is to be very, very careful about the diagnosis in the beginning of a patient's menstrual history. So I believe with the Rotterdam criteria and everything, they actually did say, you know, if a girl is starting off with her periods and she's within the first 6 to 8 years of her menstrual, her or they, their menstrual history, their menstrual cycle, then you have to be very careful about labeling them with polycystic ovarian syndrome, because it's often common to see people with a little bit of anovulation as their periods are beginning, as their cycles are beginning. So you have to kind of be careful, and then just use continued monitoring and careful monitoring, as well as biochemical tests perhaps, to make sure that they actually don't have the syndrome per se.
Are there any ways that you can to reduce some of these symptoms if you do have PCOS?
I would kind of divide PCOS into multiple categories. It's really a lifelong disorder. And so I think at the initial phases, when you see a young person who has, you know, all the criteria, you've made the diagnosis, you're like, okay, you have PCOS, and they're in their early 20s. The main concern there is, oh, I don't like this acne and facial hair, and I have no idea when my period is going to come. They're not getting pregnant now. So in order to mitigate those symptoms, you know, I think in the past we used to focus on medical treatment. So it would be like, put them on the birth control pill, which is a great way to control symptoms because it reduces male hormone levels. And sometimes we add a medication called spironolactone, which is a pill to reduce male hormone levels. Again, great medical treatment for the high androgen symptoms. But I think and one of the things I really want to highlight on this is that this is such a great opportunity for clinicians and allied health professionals to also focus on lifestyle management and changes, especially at such a young age. Things like loss of body weight can restore ovulatory cycles, like even, inducing a new exercise program that would allow you a 5% weight loss can actually reduce that insulin resistance and get your cycles to regulate. Modifying your diet, like reducing carbohydrate intake, sticking to a Mediterranean diet of like fresh foods, increasing fiber and things like that. Exercise, all of those things can actually mitigate symptoms. Mind you, the birth control pills and medication do help, and I put a lot of patients on that, but you should also encourage some of these lifestyle changes. In that middle ground, which is probably the high proportion of patients I see, those patients who don't ovulate and are trying to get pregnant, there's a variety of medications to induce ovulation. And those include fertility pills or injections to sort of overcome the anovulation and get them to ovulate in a more regular fashion. There's additions of diabetic medication like metformin to bring down sugar levels. There's actually a great over-the-counter supplement called myo-inositol that can help with insulin resistance. So I put all my PCOS patients that have an element of insulin resistance on inositol, and the studies actually head-to-head with metformin show that it's a great way to restore cycles. And then, we try to get them pregnant by restoring normal ovulation. And I'll sort of pass the baton over to Dr. Lou because she sees them in pregnancy to reduce their chances of diabetes and then in the postpartum period.
Absolutely. But maybe before we get to the pregnancy and to the postpartum, let's talk a little bit about how it can affect fertility. And then you kind of alluded to it in inducing ovulation and IVF, and then maybe you can touch a little bit on that miscarriage risk before we go on to pregnancy and postpartum.
For sure. And so, I should say first and foremost, as Dr. Lou said, I can't tell you the number of patients who come to me with that piece of paper that says, I just got told I have PCOS and now I want to conceive. What do I do? And I would say a good 10 to 15%, I'm just reassuring, saying, look, your polycystic ovaries means that you just have great ovaries. You're getting regular 28-day cycles. Keep trying and you'll be okay. But those patients who truly have PCOS, I think the biggest and most stressful issue for them, especially when they're trying to conceive, is I can't predict when I'm going to ovulate. How am I going to, have intercourse at the right time to have a baby? So oftentimes in the young population, if they're ovulating just maybe mildly irregularly and their cycles are like 30 to 40 days apart, and we don't want to add in medication yet, we'll induce something called cycle monitoring, or put them in our cycle monitoring path. So we'll monitor their cycles and we'll tell them exactly when they're ovulating. Now, infertility patients being impatient, they struggle with that and waiting around for day 21 to ovulate and so on and so forth. So most of them end up going on the pathway of using low-dose fertility drugs. Typically, this is Clomid or Letrozole. And that's a fertility pill that helps tighten up their cycles to make them ovulate in a more regular pattern. So I would probably say that's the entry-level PCOS treatment to help them get pregnant. Now, the one thing you have to watch out for when you start giving fertility drugs is risk of multiples. So there is a higher risk of multiples as you start giving fertility drugs. So typically what our aim as fertility doctors is to use these low-dose fertility pills because the multiple risk is lower, and sort of avoid using stronger medications like injectables, recombinant FSH, because that's really where in the young patient population you see the higher order multiples. That increases the risk of pregnancy complications, diabetes, and so on and so forth. You were asking about miscarriage risk.
That's right. Yeah.
PCOS does carry a higher miscarriage risk than the general population. The quota is about 30% miscarriage risk as opposed to 15% in the normal young population under 35. And that probably has to do with the environment, the high insulin environment, maybe some more pronounced insulin resistance and glucose intolerance or elevated hemoglobin A1Cs, sugar issues. Higher body weight, we know that obesity is associated with a higher incidence of miscarriage and potentially high male hormones. I would say the pendulum has really gone back and forth about metformin. Metformin is a pretty strong drug for diabetes. In the PCOS population, the evidence is really like class B, meaning that there's not great evidence that it reduces miscarriage risk. We tend to put our patients on it because this evidence is, okay. And if a patient had a previous miscarriage, it's better to put them on something to help them. But there is an increased miscarriage risk. And I would arguably say, to follow up on that because PCOS patients have a higher risk of miscarriage and they're worried about multiples when we give them fertility medication, some of them will move on to IVF to reduce multiple risk and just put in one embryo at a time. And the good thing about PCOS patients and IVF for any fertility patients is that these are the easiest patients to treat because they have lots of eggs to work with. The biggest thing you have to worry about is them making too many eggs.
Thank you so much for that thorough response. And so for anybody listening, again, we encourage you to ask any questions. This information will be saved, and you can absolutely share this with any colleagues or friends of yours that may want more information on this. Dr. Liu, let's talk a little bit about pregnancy and birth and PCOS specifically, how it can affect pregnancy and how it can affect that labor and delivery.
So pregnancy risks beyond miscarriage that Dr. Sharma has already mentioned is there's an increased incidence of gestational diabetes, an increased incidence of preeclampsia, and also an increased incidence, surprisingly, of preterm birth. And so preterm birth and preeclampsia, they actually separated these women and tried to control for the other symptomatology that they might have. So symptoms some people with PCOS may have increased BMI, and so they did try to control for BMI with when looking at preeclampsia risk as well as gestational diabetes risk. So these are separate. And so it appears that PCOS is an independent risk factor for these three things. Interestingly, a lot of women who are PCOS, they're more likely to have a cesarean section as well. So labor and delivery, increased incidence of cesarean section. Now, whether or not that's because you're seeing increased incidence of preterm birth, that's possible. And keep in mind that the preterm birth is separate from preeclampsia. So they did separate out preeclampsia, whether or not the preterm birth was because these women had increased inductions because of the gestational diabetes, whether or not they had increased deliveries because of preeclampsia. And it appears that it's separate. And it also appears that the preterm birth is late preterm birth. So these are not births that are occurring before 28 weeks. These are births that are occurring after 32 weeks. And so the increased cesarean section rate might be because of that. It also might be because of preeclampsia and, of course, a larger gestational age infant associated with gestational diabetes.
Mm-hmm. Okay. Now, is there anything that a practitioner, specifically in the allied health space, is there anything that that type of practitioner can do to make a client that has PCOS more comfortable throughout their fertility journey, but then also through their pregnancy and postpartum? So we'll start with you, Dr. Sharma.
Yeah, I mean, I think that we have to normalize the conversation, first of all. And I think, you know, a lot of women with PCOS, they struggle because they have difficulty losing weight. You know, they've been doing laser treatment and, you know, waxing and whatnot throughout their whole life. So they feel a bit of a stigma. So to encourage that comfort level, and there's actually, believe it or not, and I've been following this literature quite a bit, there's a lot about mental well-being and mental health with a diagnosis of PCOS. And so, you know, maintaining your mental well-being. And I think this is where our allied health professionals maybe do a better job than we do as medical professionals, because we're focused on the medicine and the treatment with meds. And, you know, for me, it's fertility treatment, but I think that focus on whole body holistic approaches is really a great addition. I think some of the naturopaths can, you know, really push the story about inositol. They can encourage the diet and the weight loss and the exercise piece maybe more than I could, because I am trying to change the way I counsel my PCOS patients, because sometimes it's like the quick fix is, oh, get them on some Clomid or letrozole and get them pregnant, because they do get pregnant very quickly. I call them often my first time wonders, because they come in, you know, it's PCOS, they're not ovulatory, you give them a little bit of Clomid or Femera and within one cycle they're pregnant. But I think to treat the underlying pathology and just make things better overall makes a lot of sense as well with PCOS. And I think that's where I think our allied health professionals can really help with this. Yeah, so to me, that would be the big thing in terms of working collaboratively with them.
Okay, good. And over to you, Dr. Liu. How could one really help make their client, again, comfortable? Similarly, just like Dr. Sharma said, during that pregnancy is quite challenging, as you know, the stresses of preeclampsia, the stresses of preterm birth. That is pretty daunting on many couples or individuals going through that.
I think one of the key things that Dr. Sharma just said is that to address the effect on the mental health. So it has been shown that a lot of people suffering from PCOS have low self-esteem, they have mood disorders, and they struggle with depression as well. Because PCOS is often a lifetime kind of diagnosis, right? You can control the symptoms and what's happening, but you kind of have to be prepared for what it means. And it's a hard diagnosis because it has far-reaching effects on other parts of your health. So the way I approach things in early pregnancy, particularly now, mind you, I have the benefit, like we have, I work at Sunnybrook, so we have it's a level 3 high-risk center. So I have those supports around me to be able to make referrals to the high-risk guys. And so I understand I'm lucky. So, but I think preparing a woman or a person who's pregnant with PCOS, I think that's the most important thing. So I think that you have to give them the information up front early on so that it's not like they're surprised if something happens. And you have to set out a clear management plan. So usually when I know that, let's say Dr. Sharma has sent me somebody with PCOS and she's put them on metformin, and often we won't stop the metformin in pregnancy anymore. And they'll come to me and I'll say, okay, so you have this diagnosis of PCOS. Dr. Sharma has worked her wonders and you're pregnant, and that's amazing. And then we'll talk about all the diagnoses, right? So we'll talk about the fact that, okay, we're going to do your glucose testing a little bit earlier. I typically do a 75 gram right off the bat instead of just even doing the routine 50-gram glucose challenge test. So I'll start them right off with a glucose tolerance test. I'll say, we're going to do it a little bit earlier. We'll do it by 24 weeks to make sure. We'll have you see our nutritionist at Sunnybrook, who's amazing. And then we go on after the gestational diabetes. And if you do have it, this is what will happen. You'll go to the clinic and we'll plan for an induction at around 38, 39 weeks. And we'll go on to talk about why it's important to control the sugars, the fact that you're trying to avoid hypoglycemia in the neonate, and the fact that you're also trying to help with the birth weight of the baby, that kind of thing. And then we'll talk about the fact that we'll start doing ultrasounds a little bit earlier as well, because we want to track the fetal growth. Because on one hand, you have gestational diabetes, which can increase the birth weight. On the other hand, you have risks with the placenta and placental insufficiency and preeclampsia, which can make us small for gestational age infants. So some people are like, I don't understand how you can have a big baby or a really small baby. So it depends on the severity of the PCOS, or just which way your placenta is going to react to the endocrine milieu that it's been exposed to early on. So then you start to do ultrasounds and you'll say, you know what, we'll be monitoring you also for preeclampsia in addition to the gestational diabetes. And with that, we'll also try to make sure that you're prepared that you may deliver early. If you deliver early, you may end up with a C-section, but you try to keep your eye on the ball. And the eye on the ball is that you're going to have a healthy baby and a healthy mom. And so it's a very intense first visit, but I find that it's helpful to do it earlier rather than later, because later, when they have diabetes or when they have preeclampsia, it's really hard to listen to what you're saying, and all of that goes out the window, right? All they can hear is your diagnosis. So it's better to kind of do that first visit with their partner, let them ask questions ahead of time, and then it makes them feel like they're going to be really well taken care of. And so typically, with these first visits, I know that, you know, all the family doctors and gynecologists who are on probably have very, very busy offices and practices. But if I do see that somebody has some sort of issue in terms of preconception diagnosis of PCOS or something else even, you take the 20, 25, 30 minutes to make sure that you have a good time to do that first appointment well.
Absolutely. And I think this is a really great reminder for even those practitioners that don't work in an urban setting. They work in a rural setting or in a semi-rural setting where they don't have access to so many different supports within their support network to offer clients, is to really plan out and really lay out that treatment for them, for those folks, and how that road or that journey might look for them. We're almost at the top of the hour here at 7 o'clock. And so, or 7 o'clock Eastern for those individuals that are on the East Coast. But before we go, I think we covered quite a bit of information over the last 30 minutes. And I wanted to give this last opportunity to anybody who wanted to ask any questions. But before we do that, maybe either of you could share a little bit about some of those key takeaways. What does it mean to, again, we talked about this at the beginning, but PCOS Awareness Month, it's September. What do you want to see throughout this awareness month and moving forward? Because it's not just 1 month that you see PCOS in your practices. You see it 12 months of the year. And it's important that we talk about that.
Yeah, I can start. I mean, and I think you hit the nail on the head. It shouldn't be just 1 month. But I also think, you know, we talk about the diagnostic criteria. And so I think any patient who thinks they might have this diagnosis or their cycles are irregular and they're being told, oh, it's probably just nothing, especially if you're interested in eventually having a family, or you're concerned about the future risks like diabetes. Even if you're not going to have a family, if you're concerned about those future risks, it's always better to get evaluated. And so I think it's very prudent for a patient who has any of these symptoms to go to their family doctor, feel empowered to say, you know what, I just want to get this a little bit more checked out. And so it's very easy to get a referral to a reproductive endocrinologist. And, you know, I always worry about these sort of half workups where patients are kind of diagnosed, but they're not really diagnosed, and they're not getting adequate treatment. So you know, as a fertility doctor or reproductive endocrinologist, you know, I can do a thorough history, just like Dr. Lou said, an ultrasound and blood work for male hormone levels and insulin resistance, and assess their menstrual cyclicity and say, you know what, bingo, you really are a PCOS patient. Let's talk about how we can help you. And sometimes for patients, it's planning out their childbearing sooner or later, or freezing eggs or freezing embryos because they know they have to deal with this. So I think it's really about reproductive knowledge and empowerment, and, you know, making sure that this issue is brought to the forefront so that patients aren't feeling like they just kind of have to live with it. And we're here, like we're ready, like we're happy to take care of you, even if you're not right at the pregnancy phase or right at the trying to conceive phase.
Dr. Lou?
I'm going to take a different slant, and I'm going to talk about the women after the childbearing and after all of that. And so one of my key takeaways is, please, you know, life is busy. We all get busy. Our children start to, you know, get older and they require more of our time. And I find that women think about themselves as the last person. And so I'm just going to say, don't forget to take care of yourself and to take care of your menstrual cycle. So if you notice that there's something funny going on and you haven't had a regular cycle for a little while and you're not feeling well, or if you start to notice, yeah, my hair is thinning, don't think, oh, it's just stress or it's something else, right? Because if there is PCOS, or if you've known about it for years, but you're still busy and you don't think about it, keep in mind that women with PCOS, if they're not careful about their ovulation and making sure that they are ovulating, they have an increased risk of endometrial cancer. And they also have to be careful because they also are at risk for something called metabolic syndrome, which means that it's a whole host of things where they have to really be on the ball about their health. So there's an increased risk of cardiovascular morbidity. So you have to be on, you have to watch your cholesterol, your triglycerides. So it's, I just want to make sure that, you know, the long-term longevity of your health is taken care of as well. So don't want anybody to get endometrial cancer. I don't want anybody to have an early heart attack. Everybody to stay healthy for as long as possible.
Exactly. Well said. And thank you both to you wonderful physicians who have taken the time to speak to everyone listening today, to provide an important insight on a topic that affects many individuals. And thank you for this knowledge and your expertise this evening. All
Thank
right.
you.
Well, with
Thanks,
that,
everyone.
we'll see you again soon.